Okay. Hi, everyone. I'm Jeremy Hyde. I'm an assistant professor and a radiologist at Stanford University, and thanks for having me. These are my disclosures. So I have the task of talking about core infarction on CT, which I'd rather have Martin's talk about using MRI for core infarction, but we'll figure this out. So I'm going to briefly talk about core and then get into how we do this by CT. So core infarction, you all know this, it's dead tissue. We consider it to not be salvageable, and the gold standard is absolutely diffusion-weighted imaging MRI. But how do we do this in the world where we don't have access to an MRI for every patient? Well, CT is the answer. We care about core because obviously the larger the core, the less likely you are to have a good outcome after treatment, be it by thrombectomy or thrombolysis. Okay, so how do you do this by CT? I'm going to talk about two that you probably are familiar with, one that you might not be familiar with, and I'm going to end with something that you probably haven't seen. But let's talk about aspects, CT perfusion for core delineation, and then CTA source images. So all of these different techniques are being used one way or another in randomized trial. There's always an assessment for core infarction, and I know earlier today there was a discussion about whether we should be getting away from that, but we do still use this information. So aspects is something I'm sure everyone here is familiar with. It's a 10-point scale, and you basically are assessing for the degree of hypodensity throughout the brain. And these are the standardized regions you can see on the figure. It's very important that you read the whole brain, and you should be looking for hypodensity that involves greater than 50% of each region. If you restrict yourself to individual slices, you will overcall the aspects, and that's important not to do that. This technique works, it's quantitative, but it does suffer from relatively poor inter-rater agreement. So here's a patient with a right M1 occlusion. You can see how I've windowed this very aggressively to a very narrow window level, and that's important to bring out the differences in the gray and white matter and to identify hypodensity. And when we look, we can assign an aspects. We take points off for areas that are hypodense. This patient has an aspects of 6 and is an appropriate thrombectomy candidate given the presence of an M1 occlusion. So it's very valid in the early window trials. It was used in multiple trials for selection. We've not really applied this to late window trials, so I'd just point out that we don't really know how well this will work as a selection criteria in late window trials, and that's something that requires more investigation. CT perfusion. So this has been used in more of the trials, and it does provide you with a quantitative volumetric estimate of core infarction. You basically perform a perfusion scan, and then you post-process the data to give you this volumetric assessment. There are different vendors and different ways to do it. This is one from Rapid that you can see here, and it's important to note that the volumes are not standardized between different vendors. So whatever you're using, you need to make sure that you understand it, and you understand that your core's estimates are reproducible. And I just want to emphasize that aspects does not equal core. I think this gets confused sometimes. And this is a patient from the Diffuse 3 trial to illustrate this point. So you can look at these images for a moment. And when you assign the aspects, you can see that this is a patient with an aspects of 5. Okay, we're taking off points for these regions. Here's the same patient's CT perfusion scan where we get a quantitative estimate of core. And although the patient has an aspects of 5 that would not make the patient a treatment candidate for many studies, the core is quite small, 17 milliliters. So usually people think about perfusion going the other way, but sometimes the opposite can be the problem, and aspects can inadvertently exclude a treatment candidate who is appropriate. It's important that we don't confuse the two methodologies. When we looked at the Diffuse 3 trial, this is data that's been submitted. Aspects and core behave very well if you have a favorable aspect. So you can see here patients with aspects of an 8, 9, or 10 that are favorable uniformly have small core infarct volumes. However, when you get to 7 or less, you can see there's a much wider range of core volume, and that's important to keep in mind as well. You get into an area where you don't quite know what you're dealing with as you go down on the aspect scale pretty quickly. Okay, CTA source images. So the fundamental problem with CT is you're very limited in how much information you have. There's only so much density gradation that you get from a non-contrast CT. So what you can do is if you give contrast and you look at just the raw images from a CT angiogram, there's additional density floating around because the contrast is percolated through the brain parenchyma. And that actually can be leveraged to give you a little bit better handle on an area of hypoperfusion. It does not distinguish the core from the penumbra, and that's important to realize, at least not yet. But how does this work? Well, here's a patient with an M1 occlusion on the left side, and I've outlined the core infarct in the middle panel on the non-contrast head CT. You can see it's pretty small, mainly involving a lentiform nuclei. But when you look at the CTA source images, actually that region of hypoperfusion is a little bit expanded, and you get a better sense that the core may be slightly bigger, but again, you don't know that that tissue is permanently infarcted, but additional information is present. Here's a different patient, also with a left M1 occlusion. And here's a CTA source image that's in the native brain window. This is not windowed appropriately. You need to have a very narrow window level that's close to 30/30, and when you do that, the picture becomes grainy, but you can distinguish that this is an area of very large hypoperfusion. Okay, so this is a patient who actually ended up having a very large core infarct. You can see it, but it's more easy to see with appropriate windowing. The big problem with the CTA source images is it just lacks the visual conspicuity that perfusion does. So if I outline the area of hypoperfusion on the CTA source image and compare it to a perfusion map, you can see it's just so much easier to see with perfusion, and I think that's partially limited the utility of this technique. Okay, so in the last minute and a half, I want to just spend a few slides to talk about what's new. CT has its limitations. There's only so much information. We need new technologies if we're going to be able to see the core in a more robust way. So one thing that could be leveraged is Dualenergy CT. So many of you may have these CT scanners, you might not even know it, but it's a scanner with two X-ray tubes of different energies, and you acquire images from both X-ray tubes. But that actually gives you additional information because the absorption of different tissue types varies depending on what X-ray energy hits it, and you can actually deconvolute out different parts of the brain with this information. So how does this work? Well, here's a patient who comes in with a right M1 occlusion. This is the non-contrast head CT. So it looks very favorable. If you outline the core, there's a little bit of the insula involved and maybe a little bit of the lentiform nucleus. But now let me show you from the same scan, here's a Dualenergy CT. It's just taking advantage of different energy levels. And then if I put up the perfusion, show you the cerebral blood flow, and the diffusion weighted image obtained 45 minutes later, you can see that you can identify this as a large stroke on the Dualenergy non-contrast CT because it has additional information that you don't see on a conventional head CT. And this is basically a virtual non-contrast algorithm applied to a non-contrast head CT. And this is something that's been a very interesting observation that we and a few other places have made. So CT is important. It's not going to go away. We do need some new tools to see the core a little bit better. Aspects, CTP, CTA source images are all valuable in identifying ischemia. And thank you very much.